So the red dot is exciting and intimidating. So there I was. And you all have been there or similar locations, Hudson Hospital. It was a Tuesday afternoon, nice summer day, and the ambulance brought in this young 26-year-old guy who was out riding his motorcycle. A car pulled out in front of him. He hit the car and launched in the air. He came in talking with relatively normal vital signs, and I asked him, "How fast were you going?" He said, "Well, I was going pretty fast. I was going about 40 miles an hour." He said, "I know I was going fast enough that my shoes stayed on the bike." And sure enough, he was lying there in bed in his bare feet. And I thought, oh no, this could be serious. He could be seriously injured. And I went to my ABCs. Airway, breathing, and you'll notice there's an apostrophe after the C, circulation, and the second C, CAT scan. Which brings me to the topic of this talk. Does this trauma patient need a CT scan? And in particular, we're focusing on blunt trauma today. This question became particularly personal to me a couple of months ago. I was out water skiing, slaloming by my dad's boat, and I had a really ugly crash that actually broke the ski into 3 pieces, which I didn't know was physically possible. But afterwards, it left me with these pulsatile headaches in the back of my head that after 5 days I couldn't ignore anymore. So I went into the emergency department, saw some of my colleagues, and got some scans. And this is a very intimate look at me. And fortunately, everything checked out okay, and things have gotten a lot better. So, you all have seen a CAT scanner, I'm assuming. It's was invented in the late 60s. First patient scan was in 1971 of a head, of a brain. And needless to say, it's come a long way since then. CAT scanners are usually referred to in terms of slices. How many slices does your CAT scanner have? And this really simply comes down to 2 slices is 1 millimeter. So 64 slices is generally considered pretty adequate for the majority of uses in any hospital setting. More than that are used for cardiac imaging and things where you really want to get a quick picture of the body. At Regents Hospital, we have a 320 slice scanner, which means it can scan 160 millimeters of body tissue in a single turn. As the way the CAT scanner works is within that tube you have an X-ray source and detectors that spin around the patient as the table goes through. And so with that 320 slice scanner, in one turn you can scan more or less 6 inches of a patient's body. So that's pretty darn fast. We're going to talk today about some of the risks of CAT scan, but before I talk about risks, I really want to point out that there are huge benefits to CAT scan. And if you look at this beautiful machine, you just know that that thing has some benefits. And CAT scan is every day saving lives. It's diagnosing cancers, it's diagnosing injuries, it's defining anatomy, it's guiding procedures. It's just a really wonderful thing. This is a little example of a patient I saw a couple years ago who came in a trauma, pretty bad trauma. We scanned him from head to toe and didn't find any traumatic injuries, but we did find this little thing, which was, as it turned out, a lung cancer, and diagnosed that months to years before it otherwise would have, and probably realistically did save that guy's life. It has more subtle benefits too. And I know all the physicians out there, we'll all chuckle at this, but the reality is there's many nights of good sleep I've had because of a reassuring CAT scan that I did on a patient. In addition, it can help disposition in the emergency department, move patients, help us define what's going on so that we can accurately treat them or discharge them. Now, risks, CAT scans are expensive. They're hundreds to thousands of dollars for every single one that we do. And that's something to always keep in the back of your head. It's not necessarily a risk per se, but it's something that definitely needs to be considered in making some of these decisions. Contrast-induced nephropathy or kidney injury generally is quoted at less than 2% of patients, and it's usually in patients that have distinct risk factors for that: previous kidney injury, diabetes, etc. Allergic reactions, significant allergic reactions happen in less than 1% of patients, and the truly life-threatening anaphylaxis, bad stuff, is usually even lower than that, less than 0.1%. Now, radiation is a bit nebulous. It's difficult to know the effects when we're doing the CAT scan, because at the low doses that CAT scanners use, there's no visible effect that we see on the patient when they're with us. CAT scan has become medical imaging has become the biggest contributor to a radiation exposure that Americans receive in a year. And you can see by this pie chart here, the big goldish colored slice there is from medical procedures. Generally, radiation from CAT scan or from medical imaging is measured in millisieverts or sieverts. And the doses we're generally talking about are in the 3 to 20 to 30 millisievert range. And the yearly exposure, as you can see from this chart, is in the realm of 3 to 5 millisieverts for a human being. Now, you know that radiation is bad, and it just inherently makes sense to you. And I don't know if I'm dating myself with this next picture, but radiation can take a pretty nice, ordinary, scientist-looking guy like this and give him a bad hair day. And so the younger people in the crowd do these. I know this isn't the animated Hulk that was in the recent movies, but this is the Hulk from my day, and that was from too much gamma radiation. But you know, this is what happens. The X-ray goes in and interacts, hits the DNA, causing damage, mutation, and too many of these over a period of time can cause a cell to lose control. We know it's there's a lot of debate about over the past decade or so about, with medical imaging, is this radiation that we're using truly dangerous or bad for patients? And it brings us to the central question: is this causing cancer? And we've evolved a little bit over the last year or two, in particular accepting that in patients that are particularly vulnerable, it does cause cancer. And here's two examples: the pediatric population and patients who are receiving multiple CTs over the course of their years. Looking through the literature, and I don't want to harp on the literature, but I have done a lot of reading about this. This is a review article from a gastroenterology journal that was specifically focusing on this question from a fact of colon cancer and follow-up CTs and how much radiation these patients get. But basically, they just did a lit review and found that the majority of papers out there are mentioning association between radiation and the increased risk of cancer. In the end, if you go out there, there's two studies that are being very commonly referenced, and they're shown here. Both of these studies, one was in the BMJ and one was in Lancet from the last couple of years. They were looking at young patients who've had a CAT scan. And one was conducted in England, one was in Australia, where they have these nationalized medical systems where they can track patients and follow them up quite well. And they looked at huge cohorts of patients that had CAT scans done at early years in their life. And they basically found that if we follow these patients over time, there definitely was an increase in the number of cancers. In the one study, leukemia and brain tumors, in the other study, it looked at all cancers. And they definitely found a causal relation. And they were pretty well done studies in that they took into consideration some of the caveats that we might think of in terms of, well, what if the CAT scan was done to detect the cancer in the first place and stuff like that. And they did a good job. And I think if you go out there, these are the two that really show a strong association. So how to approach this question? Well, I like algorithms. As a lot of you know, I do rock climbing. And this is me earlier this summer. I think you can see me up about 2/3 up this slide. And when I'm up on the rock, a lot of times I'm thinking, should I bail, which is climber lingo for should I go down? Should I quit this, get off this scary place, and go down? And a little closer up, in my climbing magazine 2 months ago, I found a nice algorithm, and I thought, well, that'll be useful for my climbing, and it gave me an idea for this talk. But it addressed the very question that I often come across when I'm up there. Should you bail? Well, it focuses on, well, what's the problem? Most commonly for me, it's, I'm scared. And it says, well, then why are you scared? And the most common reason I'm scared is because I'm way up there on these really little things, and I'm holding on with my bare hands. And they actually had an answer to that, which I thought was just brilliant. That's natural response. You just got to keep going. So switching gears to this talk, I came up with the ALEX Blunt Trauma CT algorithm, which basically is a little literature and some common sense, and it kind of delves into this fairly complex question. If you look at an algorithm form, we get it like this, but basically what we're looking through are a number of fairly simple questions, and I'm just going to break them down one at a time. So the very first question when this patient comes in, you're trying to make this decision, is does the patient have abnormal vital signs? And this is a very relative question, because somebody who's truly unstable probably shouldn't be in the CAT scanner. That can be a very dangerous place for them. Ultrasound is a nice option in that situation, the operating room, or a rapid transfer to a higher level of care. But if the patient isn't crashing and burning but does have abnormal vital signs, this is the patient that you should really strongly consider getting that CAT scan to find out where they might be injured and hemorrhaging. And are you suspicious of an injury? And this is kind of seems like an obvious question, but the reality is, do you really suspect that the patient has an injury in the first place? And I think, moving beyond the days of doing a CAT scan just to be safe, or a CAT scan because the patient demands it, or letting the CAT scan replace a good physical exam, I would definitely make sure that you're truly suspicious of an injury before you go ordering that. And remember the rule of complaints. I'll let you read it there. Basically, that patient that comes in screaming and yelling and is tender absolutely everywhere you touch on their entire body probably needs a little more, likely a little benzodiazepine and a pat on the shoulder than a trip through the CAT scanner. So something to think about. Next, are there high-risk features? There's a lot of literature out there, obviously, in the trauma journals looking at likelihood of traumatic injury. And there's some high-risk features that consistently come up in these studies. And I thought it was real interesting. Dr. Dries mentioned earlier, don't just base oldness on a number, but the fact is a lot of patients who are older are more likely to have significant injuries. Patients who are intoxicated, patients who have altered mental status, high energy mechanism. Remember that it's energy transfer that causes injury. So I always love it when the medics bring in photographs on their cell phone of the actual site, and it can show you either bad mechanism like this or maybe less bad in other situations. And then distracting injury. Anybody who has a femur fracture, long bone fracture, or other distracting injury, they might not be noticing that little bit of discomfort at the base of their skull, or that little bit of tingling in their left arm. Something to think about. Next, is there a clinical decision rule? Now, these are nice because they've been shown to be safe and effective, and there's nothing better than making a decision that's based on evidence and based on good studies. And there's a lot of clinical decision rules out there. Some of the best ones really focus on the head and the C-spine. For the head, we have the Canadian C-spine, New Orleans Charity rule. For pediatric, we have the PCAR and C-spine, you know that. There are some that look more at the thorax and abdomen, but I find these a lot less useful because they're less sensitive and they focus on some pretty obvious stuff like, does the patient have tenderness in their belly? Well, then you should consider getting a CAT scan. And for me, that's not very useful, whereas some of these ones up higher are. Just to show a couple of my favorite, the Canadian C-spine rule, I love this one. And the reason I love this one is because the patient, if you look up under number 2 there, can be ambulatory at any time. And that will allow you to skip radiography and delayed onset of pain, stuff like that. That's why I like the Canadian C-spine rule over Nexus. And that's why I use it every day in my practice. And then the P-card rule, which came out a couple years ago. I think this one's pretty cool because in the end, it looked at a bunch of kids and risk for head injury. And one option it gives you down in the lower right side of this slide is considering observation versus CT based on kind of some of your experience. And I think that's just a neat option that comes out. And that brings us to, is there an alternative available? So if you've kind of gone through all this and you're wondering, gosh, I still can't quite make this decision, if you have the option to observe this patient for a while in the ED or perhaps even admit them to the hospital for observation, that can be a nice option. Ultrasound, especially some of the newer ultrasound with contrast agents, not talking bedside, more radiology studies, are things that are coming along. But just to be aware that there are alternatives out there. And finally, if you've gone through and you finally I have to order a CAT scan in this patient, there is a big push in the radiology world to make sure that you're ordering the appropriate CT, and especially in pediatrics that we're dialing down the radiation. And that's something that discussion to be had with your radiologist colleagues if you're curious about what the most appropriate CT is. So putting it all together, this is what it looks like. Again, just some sort of questions to help conceptualize this order. Looking at the algorithm, it's a little more messy, but it's the exact same thing. And you can consider integrating this into either a hospital-wide or department policy. We've been using some of this at Regents Hospital in terms of actual clinical policy. And then you can consider integrating into your electronic medical record, and we've developed this in Epic. And it's a C-spine order here that you're seeing, and we actually have, you can see on there, both the Nexus and the Canadian C-spine rule built in so that you can actually use real-time your EMR to help you make these decisions. This is a reminder, if by chance you are out in the community and you do order a CT and you do find an injury that does require the patient be transferred to a higher level of care, make sure that you send the CD with the patient and maybe 2 copies because there's nothing more tragic than when a patient comes to our hospital and doesn't somehow the CD or the images got lost in transit, and we end up having to repeat a CAT scan on some of these injured patients. Which brings me back to, how did that patient fare? Well, he ended up, I just sat and watched him for about 3 hours, and I kept going in and saying, are you sure nothing new is hurting? And because I knew I had to do a CT somewhere, but consistently he's like, no, it's just that right foot that's hurting. And so I x-rayed his right foot, and after 4 hours of observation, I had him in a cam walker boot with a little metatarsal fracture and discharged him home with a little bit of pain medicines and no CT. And it was a truly miraculous 40-mile-an-hour launch in the air and land on his 2 feet. So thank you.